Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by His Excellency Dr. Jean Kaseya, the Director General of Africa CDC. And I will now hand over the floor to Dr. Kaseya to start the session. Over to you, DG.
Thank you so much, Margaret. Good morning, good afternoon, good evening. I just landed today in Geneva, and we are taking this call from Geneva. I hope to have this wonderful conversation with you in a number of topics that we prepared for you, and also what you prepared for us. Let us move on with the presentation, then we can start our conversation. Next slide. As you can see, the week was so busy. I was in Equatorial Guinea, then in Rwanda to meet the team with the three ministers, Foreign Affairs, Finance, Health, and colleagues from the State House to discuss the health financing, because President Kagame is our champion, how we are operationalizing that. Then I flew to Côte d'Ivoire for the Africa CEO Forum, and you will see now all of our leaders, when we meet, all of them, they want to have the book, the green book, with the Prime Minister of Côte d'Ivoire and with President of Ghana. I was meeting yesterday in Accra. Today, it's clear that all of our leaders, they consider rethinking African health financing in a new era is the way to move forward, to secure our independence in terms of health financing of programs in Africa. Next slide, please. We are still struggling with a number of outbreaks, and we took a strong action to have a call, a meeting with the regional director of UNICEF, the regional director of WHO Afro, and to discuss the cholera issue. As I will present, you will see that cholera is affecting us seriously in Africa. And after this meeting, I had a call with the president of Zambia, who's the champion for cholera. We agree to have a high-level meeting of African head of state the week after WHO. After WHO, our leaders, they will meet, and we need to find solutions to stop this outbreak, not only now, but also for the future. Next slide. We thank World Bank and other partners who managed to bring together key stakeholders on the Mpox response. This meeting took place in Nairobi, and what I'm hearing from all participants, it was a strategic meeting that is helping now to have even this clarity on the cross-border collaboration with all of our partners together. Next slide. We are led by the message we are giving. From 2022 to 2024, there is an increase of 41% of outbreaks. Our hope is to see 2025 going down, but it's not going down. If you compare these two maps, 2024 and 2025, if you see in blue, you'll see that in 2025, for the week 17, if we compare for the same week in 2024, there is an increase in terms of public health event. As I was saying, we still have Mpox, we have cholera, but so other outbreaks affecting our continent. Next slide. The Mpox is a yo-yo, but we are still afraid about the trend of Mpox. I want to bring your attention on this table where we are presenting 2024 and 2025 week 18. You'll see that while we are in the middle of May, we already have more than 71% of cases that we had for the whole 2024. And today we have countries like Sierra Leone and others burning, and we need to run to look for solutions. Next slide. Talking about Sierra Leone, I wanted to illustrate that. You'll see week after week, there is a huge increase of cases. I was talking with the president of Sierra Leone. I was talking with the minister of Sierra Leone. Let me tell you, yesterday we had a meeting with the AU policy organs. Africa CDC managed to secure $28 million to accelerate the response against Mpox and other outbreaks. $28 million. We have this money from yesterday. We'll use that till December to give opportunity to accelerate with the response plan 2.0 and to build a legacy for other outbreaks. Next slide. Even if we can see some trend, the previous week, there is a decline, then an increase. But if you see the map, Mpox is still a major issue in DRC. And we are still working to see how to improve the capacity of laboratory in this country, because we have still this testing coverage of 27%, and this is still too low. Next slide. Burundi, if you compare with previous weeks, we saw a decline, but there is a slight increase this week. We know that we can sustain what we did in Burundi. And I was talking with the governing board and the minister of Burundi today. I will find one day to fly to Burundi after the WHO to boost the response with them. Next slide. Uganda, it was the same trend for the past 4 weeks. We saw a huge decline. This week, we saw an increase. All of that is just to show us we are still in the middle of this public health emergency of continental security. Next slide. We are doing our best. Before this call, I attended the ERA board meeting, the humanitarian arm of European Union, to celebrate what we did together by deploying vaccines in Africa. Today, we already received 1,331,780 doses deployed in 11 countries. But we still need more vaccines. And the message is clear. There is no resistance to vaccines in Africa. Then we need more vaccine to accelerate. Next slide. Angola facing cholera, as you will see, they also got the Mpox vaccine from Spain with the Africa CDC support. Now they are vaccinating. Next slide. Let us talk about cholera. As I said, our countries, you will see in the map how it's moving. But what is the clear message? The message is there is a sharp increase in cholera in 2025 if we compare with the previous years. You'll see only in 2025, we have 110,000 cases just for the 5 months, while the whole 2024, we had only 93,000 cases, and the whole 2023, we have 108,000 cases. It means we need to sit and to discuss. This is the meeting that Africa CDC is pushing for, and we'll have it. And I wanted to thank the president of Zambia for his leadership in this area. Next slide. As I was saying, we have some more data on cholera, but it's mostly in 4 countries driving this outbreak in Africa: South Sudan, DRC, Angola, and Sudan. All of these countries represent around 83% of all cholera cases that we have in Africa. Next slide. This is the situation in Angola. You will see still a major issue, even if there is a slight decrease. Next slide. In DRC, you see an increase. And where is the hotspot? The same region, eastern part of DRC. Then we consider also what we call the Kaseya region in the center of DRC. But mostly, this part, I will have to look for a name how to call the eastern part of DRC, because this is where there is a concentration of all outbreaks that we have. Next slide. South Sudan, we saw an increase. Now there is a slight decrease, but we know that what came from South Sudan and Sudan affected Ethiopia. Then we are following that. Next slide. Sudan, we see the trend. But yes, we already discussed about Sudan and South Sudan. Next. Let us summarize by saying Sierra Leone today is a major focus, because from Sierra Leone, maybe the whole Western African countries could be affected, and we need to stop that now. Africa CDC will deploy next week staff and all other support to boost the response in Sierra Leone. We are also calling for more vaccines, because we have a huge gap in terms of vaccines to respond to this Mpox outbreak. As we said, we need an integrated approach, because we have so many other outbreaks like cholera, and we are calling for more coordination under the leadership of the Incident Management Support Team. We wanted to brief you on that. We are making progress. This week or next week in Geneva, we'll have on the 17th May a meeting with all ministers of Africa to discuss health financing. And on 20th of May, we'll have a meeting with all ministers to discuss local manufacturing. And we also know we'll take time to celebrate the pandemic agreement that was approved by our member state. Let me stop there, Margaret, and welcome questions from colleagues, journalists.
Thank you, DG. Let's take the first 2 questions from the chat group. We have Nadine Breyer from the Conversation Africa. The question is, could you let us know why the case fatality rate for cholera in Angola is so high? That's the first question. The second question is from James Kunda of Anadolu News Agency. What's the position of Africa CDC on a report that the center would have to cut some positions based on a World Bank recommendation? Over to you, DG.
I will respond to the to the second question, then the first one will be responded by my IMST colleagues. Let me first say what is the truth. Because I think when a journalist gets an information, he has to go to request for more clarity and more information. And when they provide this clarity and information, you don't consider that, I think it's not professional. I have to say it clearly and loudly. I sent an email, internal email. I say to my colleagues, we have conversation with a number of partners, how we can, in this context, push for more impact, more sustainability. We got 87 positions from World Bank. We already recruited almost 50% of these positions. Some other positions are already filled by other partners. And is there a need for us to recruit for these positions? No. Then we started to talk, a conversation with our partners, how to rationalize. And my email was clear. I was asking head of divisions to provide more information for us to make a decision, because these positions we didn't recruit for, maybe we can use this money differently. I'm so sad to see that despite all explanations we provided, this article was a fake news for us. And we really call all journalists, please, you need information, we are open. Let us do it on a more professional way, because World Bank didn't impose to Africa to cut positions. Even, in fact, let me tell you, currently there is ongoing midterm review for World Bank. They are so excited by what Africa CDC is doing. I think this is the information you have to share now to stop these rumors, unnecessary rumors, because I understand also everything around Africa CDC can become. Then, IMST colleagues, can you please respond to the first question?
Thank you so much, DJ. Good afternoon. And thank you so much for the question. So currently what is happening in Angola is that they really have, in some of the areas that are affected, poor health seeking behaviors. So many of the cases do turn up at facilities late. And this is why some of the deaths we're seeing do occur. In addition to that, as you can see, almost 33% of all the cases are children below the age of 15. And some of them do have underlying conditions like malnutrition, which also increase their vulnerability to succumbing to the disease. So these are some of the issues, but again, the number of actions have been made. And some of these actions include the establishment of rehydration points in communities to ensure that these cases are actually being attended to at the community level before even being referred to the main facilities. Thank you so much, DG. Over to you.
Thank you. Margaret, we got a question from someone in the chat. I will maybe want my colleagues from IMSC to address that. From Rachel Ido, she's asking if we can show the slide that summarizes the Mpox vaccine campaign in Africa. And is it a tremendous accomplishment to see, she's saying it's tremendous accomplishment to see how many countries are achieving this milestone. Can you please help us to see again this slide, and then I will invite Dr. Yap to comment that. Yes, Dr. Yap, can you please comment this slide?
Yes, thank you, DJ. I think we need to remind ourselves last year when we were struggling to get the vaccine. And at the time, there were only 200,000 doses that were allowed for Africa. And now, over the time, we've managed to go beyond the 1 million doses. I think this is a great achievement, one. Now we have more countries, 11 countries that are accepted the vaccine. 7 of them are already vaccinating. This is also another great achievement, especially when you come to the field. I remember when we were in Pakajuma, in Kinshasa, seeing all those lines of women and children waiting under the sun to get the vaccine. This was really amazing on how the population is welcoming. That is Pakajuma in Kinshasa. But it is the same story is currently happening in Uganda, in Sierra Leone, in most of the countries where the vaccine is made available. However, now we were here in Nairobi discussing with a different country who were highlighting Uganda was saying that they need 2.5 million doses of vaccine so that they ensure that they really control the outbreak. DRC was talking about 3.4 million doses. Though we are pushing for a very targeted approach of vaccination, with the 380,000 doses of vaccine that are available, we are really far from what we actually need. So I really appreciate that the DJ leadership who was today talking to ERA to push so that we can get more vaccine so that we are ensured that this outbreak, we can really control and contain it. Over to you, DJ.
Thank you so much. I think the main message, even from our colleagues from the US, is to help us to fulfill the commitment to have this 1 million doses that were committed to Africa, because now we need vaccines to stop this trend that we start to see again. Back to you, Margaret.
Thank you, DG. We now cross over to the floor. We have Janice from Bloomberg. Janice, you have the floor. Janice, if you can hear us. Janice, are you there?
I'm just not sure why you can't hear me. You can't hear me.
We can hear you now.
Oh, great. Sorry, so mine actually is a follow-on from an earlier question around the efficiencies and the internal staffing review that's currently underway. I just wanted to first confirm if what you'd said in response to that question earlier, if you're saying that there are not going to be any staff cuts or any job cuts. And then in line with that, last week, Dr. Ngashi was speaking about efficiency, and he spoke about what that means, being, reducing corruption, digitalization, applying other interventions that are cost-cutting, like reducing the number of face-to-face meetings. And I just wondered, he said there was an entire pillar that was addressing that efficiency that's needed. And I wondered if you could just expand on that a little bit more, specifically around what he might have meant about reducing corruption.
Yes. Yes, thank you, Margaret. Thank you, Janice. We are talking about efficiency. Why are we talking about it? During COVID time, we recruited a number of people to support a response at country level. Also, to support Africa CDC overall continental agenda. Now, we are led by these lessons, and we are asking ourselves, based on first, head cut, because this head cut is affecting all of us. Second, based on the priority for health financing, local manufacturing, digital agenda, and PPPR, in addition to primary health care, where do we think we need appropriate skills to support this agenda? This is what we are calling efficiency. Now we are reviewing that. What kind of profile we need? Because not all countries need the same profile. We are not during the COVID time. we need to support South Africa. What do we want to support in South Africa? South Africa, the minister is telling me, DG, it's not about money, it's about how to rationalize the use of my health system. Then I need someone working on the public finance management to go to South Africa, to sit with them, to help them to develop the new strategic plan. While in DRC, I still need someone who's epidemiologist who can go and sit and support the outbreak response while building the agenda of health financing. But if we speak about some other countries, it's mostly about local manufacturing. This is the anti-strategic thinking that we are going to. And are we talking about cutting staffing for now? No, we are not talking about cutting staff. What it means, cut staff? It means abolish positions where people are sitting. But if you don't have people in these positions, because you already used other funding to recruit more quickly, you are not cutting positions, you are rationalizing currently, and this is the response we sent to the journalists from DEVEX who came to us. We said, currently, we are in this process. First, because we need to go to the African Union policy organs to present the new structure of Africa CDC based on our vision. And second, because we need to align with the needs from countries. This is the answer I can give to that. Africa CDC, based on the even comment I see from most of our partners, our governance is strong, zero corruption, zero fraud. I think you will see the report from COVID-19 funds. We are so proud of that. That PricewaterhouseCoopers said zero fraud, good management of funds, and this report will be out when the COVID-19 board will share maybe next week with the chairperson of African Union Commission. I want all journalists also to help us to say that Africa CDC is a world-class organization in terms of governance. Back to you, Margaret.
Thank you, DG. Let's take the next two questions from the chat group. We have Emory Makomeno from BBC News Africa. The question is Africa CDC planning to provide assistance to the victims of Kaseya flooding in Eastern DRC, where at least 114 people died and survivors are in need of everything since last Friday? I also wanted to have the latest on cholera still in the DRC. That's the first question. The next one is from Michael Guarisa of Health Times Zimbabwe. The question is there a need for, you indicated that there's a need for Mpox vaccines. Could you clarify how many additional doses are required and over what time frame? Over to you, DG.
Thank you so much. For the two questions, I know we have experts who are working on the doses of vaccines from IMST, and I know also our colleagues are working on this response. Dr. Yap and colleagues, can you please help to answer these questions, please?
Yes, thank you so much, DJ. On the issue of flooding and cholera in DRC, so our team is working closely with the Minister of Health. So 2 days ago, they've appointed an incident manager for cholera. So we have been working with them to work on their plan for the response so that Africa CDC is better positioned to bring the appropriate support to their team. So most likely in the upcoming days, we'll have the plan and the contribution of Africa CDC. On the Mpox vaccine, we did an prediction based on the number of suspected cases that we saw. That was in March. We expect to have around 3,000 cases per week, which is actually happening currently. And based on that, the strategy of vaccinating the contact and the high-risk population, we went up to 6.4 million doses of vaccine that are needed by August. But what is important to mention is that we are not looking only at the clade 1B transmission that is happening in most of the countries where we want to stop or control the outbreak, but also countries where we have that are endemic for Mpox. We talk about part of DRC, we talk about Central African Republic, where we want to reduce by half. Because if we don't do that, who knows which mutation will come out from those countries and again will take us back to square zero. So 6.5 million to 6.4 million doses are what is needed for us to achieve to control the 1A outbreak, the 1B as well, so that at least our continent is safe for this Mpox. Over to you.
Thank you. Let's take the next two questions. We have Kemo Cham from Mano Reporters. The question is, can the Director General please elaborate on the exact kind of expertise that will be deployed in Sierra Leone? That's the first question. Then the second one comes from William Jabba from the Liberia Broadcasting System. The question is, looking at the efforts of Africa CDC to tackle Mpox on the continent, and yet the number of cases are still on the rise. I want to know what are the causes of the increase in the number of cases on the continent. Over to you, DG.
Thank you so much. I think we wanted to call for the ECG on the 18th. We are thinking that cases were declining. Then we saw a huge increase, even new hotspot. The ECG will meet on the 30th. I think, if I'm not wrong, Dr. Yap will tell me, but I think it's the 31st of May. The ECG will help us, based on all the information that we have, to understand what is going on. We had our review, and we want to sit with our experts to understand how can we prevent this Mpox to continue to be not only a public health emergency of continental security, but also a public health emergency of international concern. As you know, WHO is calling for a meeting in June for the HR committee to discuss if it's still public health emergency of international concern. I think this is where we are. But in terms of expertise in Sierra Leone, we are bringing the full package. Epidemiologists to understand the situation in the field. We are bringing lab experts to reinforce the capacity of the country. We are bringing colleagues for community support to train more community health focus. We are bringing colleagues for infection prevention and control, for case management. It means we are sending around 25 people in Sierra Leone, in addition to vaccines, in addition to all other areas of support. Sierra Leone today becomes one of our major priorities. And I want to stop this outbreak in Sierra Leone to prevent a huge spread in other Western African countries. Over to you, Margaret.
Thank you, DG. Let's take the next question from Paul from the Lancet. Paul, you have the floor.
Thank you very much, and good day to the DG. My question is on making the quality and reach of health initiatives on the continent to be focused on more local approaches. What am I trying to say? We've seen this increase in restrictions around donor funding, and there is this perception among experts that a lot of this donor funding are no longer coming back. And we continue to see, especially in today's conversation, one of the goals has always been Africa needs more vaccines, but we are still looking at preventative measures that are not vaccine related. Are you concerned that the increased conversations around vaccines will still be limiting the attention to preventive measures that may be more cost efficient? And if you look at the broader strategy of lowering the cost of doing public health on the continent, prevention is always still much cheaper than trying to control. If you remember during the financial impact of the COVID vaccine, one of the concerns was that if we had spent 1/10 of what we spent in controlling the vaccine as prevention, we could have made a lot of progress. So how do you see, or how is the Africa CDC aggressively prioritizing prevention, which is in its name even more than control?
DG?
Thank you so much, Paul. Everything is about a vision. We have a clear vision. I think you saw us appointing a substantive director for primary health care. We didn't have this position before. And even the person we appointed is a person who decided to leave UN organization to sit and to be an Africa CDC staff. Around the primary health care, we are bringing this component of prevention. We talk about vaccination, we talk about nutrition, we talk about wash, we talk all of these components. And this component are around the community health workers. There is no one who can help a community to prevent outbreaks like a community health worker can do. But we need to train them, we need to equip them, we need to put in place a system of alert. Paul, this is our major priority today. Because you are right when you say we need more prevention than the curative approach. But when we talk about prevention, we need also to manufacture our own product. This agenda is really moving. We know, and I have to say it, not so many partners, not all partners are helping Africa for this agenda. You can quote me. We want all of them to support our vision. Don't come to say you are supporting us if you are not following our vision in Africa. And this agenda is not an agenda of Africa CDC, it's an agenda of all African leaders. This is why we will celebrate in the next 3-4 years the first 8 vaccines coming from Africa. We managed to put in place a pool procurement mechanism. In the coming weeks, you'll get the good news of this African pool procurement mechanism, signing agreement with some key partners, because we didn't sign, I don't name them, but I know who are coming to sign with us. We also managed to put together, following the Pan-African Health Organization model, our national regulatory authorities, because that one is used as an excuse to say that Africa doesn't have capacity on the regulatory aspect, while we are supporting the African Medicine Agency. Believe me, we are really moving with this agenda and we'll make progress. Paul, I will come back to you regularly for some update on this area.
Thank you, DG. Let's take the next 2 questions. We have a question on the incident management support team. The question is, the IMST has a new plan. What does this plan entail? And in the light of funding cuts, how is the IMST plan being financed? Then the next question comes from, we have Michael again. The question is, what specific initiatives have African governments, public health researchers, and policymakers launched to mitigate the crisis since the foreign assistance halt? Over to you, DG.
Let me talk about the second one, and because the first question is specific to IMST, we have strong colleagues. It's the first time to see all of these very strong people coming together under the IMST. We need to celebrate this success. But what are measures that we are putting in place? There is nobody who managed to bring African leaders like Africa CDC did. We had 3 meetings of head of state to talk about the crisis, ideas, document. We have 5 meetings with all ministers. You saw me flying to Washington, Norway, Sweden, so many other countries, bringing partners together, aligned to what Africa CDC is doing. If I see my agenda in Geneva, there is no space because everyone wants to understand how did you manage to bring this together. You saw a number of photos, even a few of them I show you. Today we have 12 head of state of Africa showing the Green Book. They are calling that the Green Book. We are proud as Africans. We didn't wait for other continents to come to think about. We started to. But if you read this Green Book, it's really what we call rethinking. It means Africa is saying clearly, let us have more domestic resources. Do you know we still have middle-income countries in Africa investing around 1% of their budget for health? 1%, while they are middle-income countries. It means they can increase domestic resources. Second, let us have more innovative financing. While in Europe, while in the US, when there is a specific problem, people can put taxes. We need also to put taxes in Africa. Then we talk, the third one is the blended finance. How to create conducive environment. Do you know that we just need $15 million to have a manufacturer plant for BedNet? We have so many people in Africa who have $15 million. Why we are not doing that? Maybe because they didn't have information and we didn't create the conducive environment. Africa is creating this conducive environment, even with the African pool procurement mechanism. I think this is what I can say. We took a number of actions, and what we are doing now, and this is the information I want to give you, under President Kagame's leadership, under President Lorenzo's leadership, we are putting in place a committee, high-level committee, that will drive the implementation of the Green Book. Please follow us on what we are doing. You will see the face of Africa will change. Colleagues from IMST, please respond to the first question that was addressed to you.
Thank you, DJ, and thank you so much for the question on the IMST and the new plan 2.0, which focus on three points. The first one is really the identification, as you rightly mentioned. We want to scale up the vaccination. We want to scale up the decentralizing of the laboratory so that the lab are closer to the community and that within 24 to 48 hours, the suspected case to have the results so that we can really manage the outbreak. We need to digitalize also the surveillance with the community health coworker that you just mentioned. And of course, the IPC and the case management. So the intensification, but also the integration of Mpox in the national system. We want, when the kids are coming to us with those symptoms, they also to be screened for measles, who are even killing more than Mpox. So for that, we have the technology for the lab, the multiplex testing, so that we can make the difference. So intensification, integration, and then the legacy. We really want the exposed country to be different before the Mpox, after the Mpox. And this is working. We moved from 2 labs in DRC able to test for Mpox to 29 laboratories. In Burundi, we moved from 1 lab to 54 laboratories. So this is what we want to see, that this Mpox outbreak has been an opportunity. Now, we as mentioned, we are in Nairobi, where we were discussing how to do more, better with less, because the resources are being constrained. We know all the global environment where there are quite a number of cuts, and we have this tool that we call the financial tracking mechanism that allow us to follow the pledges, what the donor has promised to give, the disburse, what has actually been donated, and then find out the commitment, what is still pending. And in our new plan, which is around $499 million of US dollars, because of what has been pledged, we did a very good job under your leadership. during the first phase, we managed to have 1.1 billion pledge. So if we take the commitment that the donors has put aside, apart from the USG, we have $196 million that must be available to help us moving on this new phase. And yesterday we had the great news that you shared with us that the member states are putting almost $30 million to support Mpox and other health emergency of Africa CDC, which is really aligned with the domestic funding that we are talking about. So we believe that with the catalytic support that we are getting for our member state, the other donors will also follow up, because if Africa is safe, then the entire world will be safe. Over to you.
Let's cross over back to the floor. We have Lucia from the Spain International News Agency. Lucia, you have the floor.
Hi, can you hear me?
Yes.
Yes, we can hear you.
Well, thank you so much for your time. I wanted to ask about the meeting that is planned for Saturday about the emergency, the continental emergency for Mpox. Is it confirmed that it's going to happen, and do you plan to communicate on it that same day, and how will you communicate? Thank you so much.
DG?
Yes, I think, Lucia, you are talking about the emergency consultative group meeting. I was talking about, I say, no, this meeting was called for the 18th. This is exactly what we are talking about. But now the meeting is pushed end of May, because we are accelerating in Sierra Leone, in Uganda, in Burundi, in DRC, and we want to give more evidence to the ECG, Emergency Consultative Group, to make a decision. I think for now, Dr. Yap, you can tell me when you discuss with Professor Salim, what is the date that you finally decide to have for this meeting?
Well, thank you, DJ. So the date has been agreed on the 30th of May so far for this meeting to handle.
Thank you.
Let's take the next two questions. We have a question from the chat box. The question is on the rising cases of cholera across 15 countries. What will it take for Africa CDC to declare cholera a continental health emergency? And then the second question we have here is on the community health workers in the fight against outbreaks like Mpox and cholera. What is Africa CDC's strategy? Over to you, DG.
To declare a public health emergency of continental security, we need to bring the ECG. And this meeting, they will also discuss not only Mpox, they will discuss all outbreaks that we have in Africa. And they will give us the guidance. I told you, the week after WHO, our head of state, they will meet. They will consider a number of factors. We are talking about the week of the 26th. Then, with their guidance, we'll go for the ECG meeting. If the ECG, they consider that all of this evidence that we have must push Africa CDC to declare cholera a public health emergency of continental security, we'll do that. But we want to be led by science, not to be led by politics. This is why we'll give them evidence, and IMST colleagues are working closely with other partners to provide evidence for this declaration if it must happen. Colleagues, for the second question, maybe you can respond.
Yes, thank you, DJ. So the community of care workers, they don't work on their own. They are part of the system. So for this specific outbreak, Mpox, Africa CDC and the IMST is deploying over 3,000 community of care workers in DRC, in Uganda, in Burundi, Sierra Leone. So in Burundi, for example, we decided to extend because, as you rightly presented today, we can see that for the last 3 weeks, we've seen some slight increase on the number of cases. So we really want to get to 0 cases. So therefore, we need those community healthcare workers to still be on the field, to work with the field epidemiologists, so that in the intensification, they can do the house-to-house screening. The epidemiologists can confirm all the alerts, the sample being collected, and then to ensure that the IPC and the treatment being very well organized. So we expect that that intensification will allow us to strengthen the surveillance. And we all know that the surveillance is also connected to the vaccination, because we have a shortage of vaccination. Until we get more, we really have to have a targeted approach. And this means that the contact of the case are being vaccinated. And that rely on the surveillance, that rely on the active screening of the community healthcare workers. So they play a critical role, but they are part of the system. They are not people that we bring from out to respond to the outbreak, but they are people from the community. So they are respected, and it's aligned with the Africa CDC mission vision of ensuring those people are being professionalized, because we ask them to work for Mpox, but we also ask them to work for polio, for many other diseases. So this is an opportunity to ensure that after the Mpox, one of the legacy was really be to ensure that the community healthcare workers are really professional part of our healthcare system. Over to you.
Thank you, Prof. Let's get the next question. Abdullahi, we're coming to you. You have the floor. Abdullahi, can you hear us? Oh. All right, let's take the next one. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there.
Yes, Kemo, we can hear you. Go ahead.
Hello.
We can hear you, Kemo. Go ahead.
Yes, I just need.
Kemo, we can hear you. Okay, let's take Abdullahi, if you can hear us. Go ahead.
Hello, I was muted.
Okay, go ahead.
Hello, can you hear me?
Yes, Kemo, we can hear you. Go ahead.
Okay, sorry, I just needed a quick clarification on the DG's response to my first question. You said, you explained very well that you'll be deploying 25 epidemiologists and all the areas of concern, but you also said in addition to vaccine. I wanted to know if that addition is the remaining vaccine that we have, or if it is an addition to what had been promised earlier.
Thank you, Kemo. Let's take the next one. Abdullahi, can you hear us?
Yeah, I can hear you. Can you hear me now?
Yes, we can. Go ahead.
All right. So good afternoon, DG. So I just want a quick clarification on the vaccination challenge we are having in Africa. And I would like your in-depth response as regarding that. So concerning vaccine production, what exactly is the major issue we are having in Africa in terms of having to produce them locally rather than having so much of international dependence? What exactly is the major issue we have as regarding our local production of vaccine? Thank you, DG.
Over to you, DG.
Okay, my colleagues are working with Sierra Leone on the vaccine. They will provide information, even if I have information, but I like to give the leadership to IMSC for that. In terms of vaccine production, quickly, it's a very complex component that is bringing not only financing, but technology. This technology can come either from research and development or from transfer of technology. We are talking about regulatory aspect. We are talking about the market. What Africa CDC is doing is to work with all other AU organs and partners. On the financing, we already secured 1 billion from the European Union, 1.2 billion from Gavi with the program we call AVMA, 2 billion from Afreximbank. This money is available depending on the conditionalities, but the money is available. In terms of tech transfer, we are working on the tech transfer. And currently, so many African manufacturers, they got the tech transfer. On the regulatory aspect, we are working to, as I said, we managed to put together the 8 national regulatory authorities maturity level 3 for them to start to give us a bit confidence, because we know the challenge remains also with the what we call the WHO pre-qualification. But we can start to produce, to assess the quality of our national regulatory authorities and to start to use that, especially when we have this kind of emergency. The last one is the market. People are telling us we don't have market in Africa. We have 1.4 billion people. This is the market. Yes, it was not well structured. This is why we decided to put in place an African pool procurement mechanism. I can assure you, Abdoulaye, things are moving. And now that we are regularly updating you, you'll get some update from us on the way it's moving. Dr. Yap, on Kemo's question about additional vaccines for Sierra Leone.
Yes, thank you so much, Kemo, for the question. Maybe just to remind how the process worked. So our team was very close with the country team to assess the needs, which is part of the plan for vaccination. Then it goes to the technical review committee, which will then allocate the vaccine to countries. A few weeks ago, 750,000 doses were allocated to DRC, 500,000, and 200,000 to Uganda. So we had a mission a week ago from IMST to Sierra Leone to discuss with the team and properly assess, one, is the plan being implemented properly in terms of vaccination? We realized that out of the 61,000 doses that has been allocated to the country and delivered, they've already used 30,000 of them, half of them. In the initial period, they were mainly focusing on the community, on the healthcare workers, while the main target was the sex workers and others. So they adjust the strategy so that they can really focus on the key population. That is a very good point. Now we are getting the feedback from them and working together on finding how much dose they will actually need to move forward using that very targeted approach. Based on that, we'll go back to the TLC so that a number of those are allocated to them. But as mentioned initially, the amount of those available at the global level, around 400,000, it's not enough. It's not sufficient. So we'll need to mobilize much more dose. And as DG mentioned, to work toward the local manufacturing of vaccine, because we won't be able forever to rely on our donors, our partners to support our community. Over.
Thank you, Prof. I now hand over back to DG for his closing remarks. Over to you, DG.
I took 2 weeks without talking to you. I was missing that. But I will do my best to be there regularly. Even if I'm not there, we have strong people. I think you saw Dr. Yap, you saw Dr. Ngashi, and so many other people. I think the 500 staff in Africa CDC, all of them can maybe take this call because we are strong. Wanted to say this week, the major focus, the health financing. We are meeting in Geneva to discuss that. The second one, local manufacturing. The third one is to celebrate the pandemic agreement. But let me also say something important. All of us, we can make mistakes. We saw Time Magazine made a mistake. A former colleague of Africa CDC, they called him head of Africa CDC, lead of Mpox response. When Time Magazine discovered that they made a mistake, they corrected that. You can go, you will check, you will see the correction. because the head of Africa CDC, Jean Kaseya, the person leading the agenda is the DG, then they corrected. We want also the VEX to correct the misrepresentation they made with their previous article. If they don't want to correct that, we take it like it's in the purpose that they did it, and that one is not professional. With that, I hope to see you next week. For those who will be in Geneva, please let us have conversation. Thank you so much.